Thank you. Hi, good morning. Thanks for coming. Any questions during the talk, just raise your hand and give me a holler, and we can stop, but it's very informal. So today I'm going to speak about pediatric hearing loss. So the kind of when, where, what, how, and why, what we look out for, and what we need to worry about. So the incidence and prevalence in both newborn and in general pediatrics. The incidence in newborns is fairly low. It's only about 3 in 1,000 children are born with a true, what we call a sensorineural hearing loss, a problem with the cochlea or the nerve or the brainstem. The problem is that if those children are unrecognized, that they don't develop normal speech and language skills, and then they get behind the ball. So the big deal here is that the speech centers of the brain do not develop without adequate auditory input. So what I mean by that is if you take someone who's 20 years old and they've been deaf from birth and you magically restore their hearing to normal, they will never develop normal speech and language because the part of their brain that controls speech and language will not develop, and that window closes. It's a continuum, but it's pretty well closed by 5, 6, or 7 years old. So that if you miss a hearing loss and then you pick it up at the age of 4 or 5, they may never develop normal speech and language skills, even if they have a high IQ or other or something quite or extraordinary brain. If you take someone who's not very bright and you restore their hearing at the age of 1, they will, with the proper therapy, they should develop normal speech and language skills by the time they're older. Now we can screen with otoacoustic emissions or ABRs. In the state of Arizona, all of the hospitals have developed voluntary screening programs. It used to be mandated in certain states. It's not mandated here, but it's put into all the states. It's put into all the hospitals, rather. They can screen with either otoacoustic emissions or ABRs. ABRs are a little bit better, and ABR is called an auditory brainstem response. So it's a non-invasive test where we put a recording electrode on the forehead, a recording electrode on the mastoid, no transcutaneous, all just sitting on top of the skin. And then we put on headphones, we put a sound into the ear, and we record the differential recording going up through the brain, and we can determine their thresholds to within 5 or 10 dB. Otoacoustic emissions is where we put a sound into the ear, and the ear talks back to us. And then we can determine whether they have normal hearing. ABR is a bit better test than an OAE. The hospitals usually make these decisions about whether they want to screen with an OAE or an ABR. An OAE is a cheaper method of screening. What most hospitals do is they screen with an OAE, and then they'll use an ABR afterwards if they fail their OAEs. Early detection costs about $20 per child. It's kind of bundled into the birth fee. So if Blue Cross and Blue Shield pays X for a woman to come to the hospital and have a baby, this gets bundled into the fee. It's not brought out. And the net on that is it's about $3,300 per hearing impaired child. And the thought is that if you can pick up a hearing impaired child, that fee will be more than covered because they will be recognized earlier, get the appropriate therapy, and they will become mainstream. They'll be able to go to normal hearing school, use the public school system, use the public universities. They won't require sign language interpreters, etc. So what are the risk factors with hearing loss? History of meningitis is a biggie, PICU, craniofacial abnormalities, family history, ototoxic medications, increased bilirubin, poor APGAR scores, or Torch syndrome. Torch syndrome is toxo. Other, which includes syphilis and the new Zika virus. R is for rubella, C is for CMV, and H is for herpes virus. The biggie here for us is CMV. CMV is a very tricky virus. You can get diagnosed with it early, and you can have normal hearing, and the hearing loss may not express themselves until they're at 3 or 4 years old. So we're always chasing down CMV, following those children closely. How do we diagnose it? Well, the gold standard in children is a behavioral audiogram. The behavioral audiogram is you put them in a booth, you have them throw a block in a basket, you have them look over at Winnie the Pooh, you have them do various behavioral things in the office to see if they pick up the hearing. The problem with a behavioral audiogram is it's not always reliable until they're older, and then in the pediatric population, you frequently can't get them to wear either headphones or ear inserts to get ear-specific information. So they may respond to sounds in a sound booth, but as soon as you put the headphones on them, they get upset or they won't tolerate ear probes. Otoacoustic emissions is what we talked about earlier. You put in probes in the ear, you put a sound into the ear talks back. If we used what we call distortion product otoacoustic emissions, we can come up with thresholds that we can guarantee that are maybe 30 or 35 dB below 30 or 35 dB, and that would let us know that they're in the ballpark. You can't get specific thresholds, meaning you can't ladder thresholds with OAEs, but you can determine if there's something there or not. Auditory brainstem evoked potential study, again, the best study for children in whom you can't do a behavioral audiogram. So this would be children that are not going to respond in the booth. Maybe they have developmental delay. Maybe they're poorly cooperative. With with an ABR, you can do them on children below, say, 6 months in the office with sleep deprivation, but you can't do them between maybe 6 months and 7 or 8 years. They just won't tolerate the headphones in the office, and then you have to do them under general anesthesia. General anesthesia does not adversely affect the results. So this is what we call an audiogram. So an audiogram is kind of what we look at. On the y-axis is threshold, meaning how loud we have to turn the sound up for them to hear it. On the x-axis is frequency. So over here, I can't get this to work for some reason or another. This is the bass over this side, and this is the treble over this side. Anything above or equal to 25 is normal. So this would be what we call a normal audiogram. So a way of reading this is if we go to, say, 500, which is roughly middle C on the piano, and we follow it down, we hit a red circle, and we read it as red, right, round. Red circles correspond to the right ear, the round symbols correspond to the right ear, the blue X is the left. So when I follow down at 500, I hit a red circle, I follow it over to 0. So when I turn middle C on the piano up to 0 dB, the right ear nails it, okay? Follow it down, you see the X is at 5. When I turn middle C on the piano up to 5 dB, the left ear nails it. Anything equal to or fewer than 25 is considered normal. So this would be a normal audiogram. This is called a tympanogram. This is when we put a puff of air into the eardrum and the eardrum flexes in and out. And we can determine if the eardrum is mobile, and that can be useful in diagnosing otitis media and things like that. So basically we got 3 parts. We have the ear canal, the eardrum, the 3 ossicles, the cochlea, the nerve, and then it goes to the pons. We considered a conductive hearing loss to be anything from here out. So if it's from the ear bones, the eardrum, conductive. If it's from the cochlea, the nerve, or the brain, it's considered sensorineural. Oh, thank you. Thanks. So let's look at these 3 kinds of hearing losses. Conductive, we know, is from the ear bones, the eardrum, or the ear canal. Sensorineural is from the ear, is from the cochlea or the nerve. Mixed is both conductive and sensorineural. And this is what we'll typically see in older people. They'll have noise-induced hearing loss coupled with an effusion in their middle ear space. So that's a mixed loss. Auditory dysynchrony is kind of a different beast. Auditory dysynchrony is when we hear, the cochlea not only hears the sound and detects it, so you raise your hand when you hear the tone, but the cochlea has to take it and code it in a very complex manner so that when that sound gets presented to the brain can sort out that it's a word. Otherwise, it's gobbledygook. With auditory dysynchrony, the sounds are not presented to the brain, the electricity rather, is not presented to the brain in an organized, logical fashion so that they can sort out that it's a word. So they'll have thresholds. They may be able to raise their hand when they hear noises, but it's almost like white noise on a TV, or it's almost like gobbledygook to them. They can't discern words. They can't hear very well because their cochlea is not organizing the sound very well, or their nerve is incapable of taking that sound, that wire, and bringing it up to the brain in an organized fashion. So how do we determine if they're hearing impaired, or what are the big deals? Speech milestones are kind of everything for us. We're always worried about, are they developing normal speech and language skills? Even if they pass their normal hearing screening and they come in and they're 2 years old and mom said, he's not saying anything, he's just grunting, or she's not, her older sibling was speaking by this age and they don't have any speech. So we worry about the milestones are a big deal to us, and then we say the sound must get into the brain for the speech centers to develop, and the window closes in early childhood. So that's the whole idea of making sure that we pick up these kids early, we treat them early and aggressively. So these are just some speech milestones. I'm sure most people know this. There's obviously some variability to it. Boys as a general rule tend to speak a little bit later than girls. Sometimes children with a lot of older siblings don't speak as much because their older siblings tend to speak for them. So there's a lot of social issues that go into this, but we also just want a ballpark figure where if someone comes in and they're 3 years old and they're not speaking, that we kind of know what, we go down our diagnostic list and say, what do we need to worry about? A lot of the school districts won't let someone get a speech and language eval if they're below a certain age. They might just say, we won't evaluate kids for speech and language skills below the age of 4. Because the school districts, even though the kids are not in school, will typically provide speech and language services for them, but they want to make sure that it's actually a real speech delay and not something more. So then a lot of those patients will come and see you or me and say, they're 3.5 years old, they're not speaking well, what are the issues that go into this? And most speech and language programs will require an audiogram before they will begin speech and language therapy, because they don't want to have a kid in a long speech program if the reason they're not speaking is they have delay in speech and language skills. So I won't touch much on what Dr. Redfeld's going to talk about later, but basically conductive hearing loss, common things happen commonly. So the most common cause of hearing loss in children is eustachian tube dysfunction, and that can either be retraction, the eardrum gets sucked backwards, or just fluid behind the eardrum. Chronic otitis media is the second cause, and that's perforation, a hole in the eardrum, cholesteatoma, which is where the eardrum gets sucked inside out, if you would. In acquired cholesteatoma and congenital cholesteatoma, it's when there's a nest of skin that is developmentally stuck in the middle ear. When the middle ear seals off, that skin has no place to go, so it grows in the middle ear. And ossicular discontinuity, which is a cause from chronic otitis media. And then congenital oral atresia is when you either have a maldeveloped or you don't have an ear canal. You'll typically see it with congenital microtia, where you'll see a malformed ear, and that's a branchial arch issue. It is when it happens at about 6 weeks post-gestation. So this is just a great picture of a retracted eardrum. This is the malleus, this is the incus, this is the promontory of the cochlea, and the eardrum is sucked down against it. It can't move. This will present with an audiogram that will show about a 20, 30 dB conductive loss. This is serous otitis media, malleus, incus, and amber effusion, keeping the eardrum from vibrating effectively. The audiogram will typically look like this. There'll be what we call a conductive hearing loss. Now these brackets up here are where the thresholds are if we present the sound directly to the cochlea. So the bracket means, for instance, let's look at 500 again. Middle C on the piano, we'll look at the right ear. When I put the sound directly into the cochlea, they hear it 5 dB. When I put the sound in through the ear canal, they hear it 45 dB. So they're losing 40 decibels of sound between the cochlea and the outside. So that would be a 40 dB or 40 decibel conductive loss. The left ear is in the same boat. Bone conduction thresholds are a little trickier to get because you have to put a bone vibrator on their head. Sometimes kids are less tolerant of it, and there's some tricks with getting it because there's an issue of what we call masking. Masking means if I make you deaf in your right ear, if you're deaf in your right ear and I put sound into your right ear, when it hits 40 decibels, it's going to go over to your other ear and you're going to hear it. So we have to do these audiologic techniques to mask out the good ear so that we can get accurate thresholds in the bad ear. So this here is a perforation. This is a big old hole. This is typically from chronic otitis media. This would be a left ear. This is the round window niche here. This is the promontory of the cochlea. This is the malleus retracted here. This is the incus. This is the tendon, the stapedius tendon right here. So this would cause about a 40 to 50 dB conductive loss. And then once you hit a certain spot, you can't get any more of a conductive loss. It's called a maximum conductive loss. So if I took out my ear bones and my eardrum and then put a cuff on my ear and I effectively masked out my other ear, when I got up to maybe 45 or 50 dB, it would cause the fluid in my cochlea to vibrate and I would have a threshold. So when you hit what we call maximum conductive loss, you can't get a hearing loss any worse than, say, 45 dB. And this is a cholesteatoma, which is a growth up here. The eardrum has a very weak part in the straight superiorly and posterior superiorly. It's called the pars flaccida. So the eardrum has 3 layers, an outer skin layer, a middle fibrous layer, and an inner mucosal layer. The most fragile is superiorly, where it doesn't have a middle fibrous layer. So think of if I broke a balloon and I held it in my mouth and I sucked in and I started causing a concavity. That concavity can grow in and almost form a balloon. And then that balloon is lined with skin and it keeps shedding the skin and it forms a cholesteatoma, which destroys the ossicles and destroys the drum. So how do we treat these? This is what would be a unilateral conductive hearing loss right here. So the treatment of eustachian tube dysfunction is obviously to eliminate the risk factors, right? Commercial daycares are a biggie. You can't help it sometimes. Obviously, smokers in the family. We treat it medically, and then we treat it surgically with tympanostomy tubes. Tympanostomy tubes and adenoidectomy is another common way of treating it. And this is a PE tube here. This is a long-acting PE tube or a T tube. The other way, how do we treat other kinds of conductive hearing losses? So this is a commonly used, we call it ossicular reconstruction. So the incus is the second ear bone. It is the most fragile of the ear bones. It has the weakest blood supply. It's the only bone in the body that has no soft tissue connections. So it's between the malleus and the stapes. Its blood supply has to cross 2 joint spaces. So this joint space here at the top of the stapes is less than 2 square millimeters. So when you see these people, they will typically have an eroded incus, and then we put a prosthesis between the top of the third earbone rather, and we run it up to the eardrum. Here's the eardrum up here. This is cartilage to help hold it in place. And the eardrum's pretty slick about determining if something doesn't belong there. So it will extrude it. So we kind of trick the eardrum by putting cartilage here so that the eardrum doesn't see the prosthesis and the eardrum doesn't try to push the prosthesis out. So sensorineural loss is really the biggie here. There's congenital and acquired. Congenital, again, is only about 3 in 1,000 births. And acquired is more common than that, but not much more common than that. So if you see together, those two in someone maybe 5 or 6 years old, the incidence of true sensorineural hearing loss will only be about 6 to 10 per thousand live births. So let's talk about auditory dysynchrony again. They're able to respond to sounds, but they can't discern words. The cochlea is coding the sound, it's transporting the signal. The diagnosis is that they can respond to sounds, but they don't have any discernible speech. Their ABR doesn't show distinct waves, so it's not being conducted up to the brain in a logical fashion. And the diagnosis is made by normal otoacoustic emissions, meaning the ear hears something, but they have an abnormal ABR, so the ABR does not have nice distinct waves that are conducting the sound up to the brain in an ordinary fashion. So think of this, think of the sound coming in, it's striking the eardrum, the malleus is moving, the incus is moving, the stapes is moving, the cochlea is coding it, and then it's coming down here and going through this scrambler in the nerve that's not allowing that sound to be presented to the brain in an organized fashion. I don't really understand what this is, but you will hear this term. Central auditory processing disorder is kind of this catch-all term that people will use for people who have trouble with background noise, they will have trouble, they're not developing normal speech, and we don't know what to attribute it to. There's some people who do testing for it. It is just something that there's really very little objective standards for it. A lot of people feel better about having a diagnosis of it. If you have a child that has normal hearing thresholds, who's not on the spectrum, the autism spectrum, and then is not developing normal speech, a lot of them will be given this diagnosis, and they'll be given various therapies for it, but the therapies are suspect, and we just don't have a good understanding what it is. But you'll hear people say we do CAP testing, or we treat people for central auditory processing disorders, and it's a very controversial, non-objective diagnosis. It's just one of those terms that you should be aware of. So let's talk about this test again, this auditory brainstem evoked potentials test. It's objective, it's not behavioral. So we can reliably get thresholds 5 to 10 dB off. It's non-invasive, three surface electrodes, sound probes in the ear that look kind of like little iBuds. Before 5 months, no sedation's required. After 5 months, it's hard to do. It's hard to sleep deprive them, have them come in the office, give them a big meal. They want to take a nap and try to get that test done. It takes 30 to 60 minutes. And what's key here is we feel that it's really important that the patients be optimized before the test. By optimized means you don't want to waste a general anesthetic or waste this test if they're having eustachian tube dysfunction, and you do the test and they show to have a unilateral conductive hearing loss that's from fluid in the ear. So we want to make sure before they have this test that they are completely optimized from a eustachian tube standpoint and from a medical standpoint, so that they don't have the test. A lot of people will do tympanograms beforehand to make sure that their drum is mobile. They'll do a diagnostic myringotomy if it's done under general to make sure that their drum is, that there's no fluid in the middle ear space. And when you get this test, you're not going to get any conductive component unless it's truly an ossicular problem or another problem. You don't want to do this test to diagnose unilateral serous otitis media. That's kind of an inappropriate use for a test like this. Let's go back to those issues now. So what do we do for the big hole in the eardrum? We can fix the eardrum with a tympanoplasty. Most of us will not want to do that until the children are closer to 7 or 8 years old. When we look at a graph of eustachian tube dysfunction versus time, we think that the eustachian tube in over 95% of children is normal by the age of 7. So what we don't want to do is put in a set of tubes on a 2-year-old, have them for bad eustachian tube dysfunction. The drum breaks down. They have a large perforation at the age of 3.5. Then fix that perforation with an operation. Then they get fluid back behind the eardrum, and then you have to put a tube through a grafted drum. You want to wait until you're reasonably certain that they have good eustachian tube function before you do a tympanoplasty. You don't want to get in the habit of kind of making a hole, fixing a hole, making a hole. Grafted drums don't heal very well. They tend to be more fragile. So you really want to make sure that you're not tempted to do these operations early, whereas you're not reasonably certain that they're going to have good eustachian tube function and they're going to be able to tolerate an intact drum. Some kids can't tolerate intact drums until they're older. They already had tubes, and a lot of perforations are from tubes. A lot of them are from severe acute otitis media with spontaneous perforations. Cholesteatomas need to be removed ASAP. As soon as you diagnose them, they should be removed. If they're congenital, they can be removed 3-4 years of age. If they're acquired, they can be removed at the initial diagnosis. This is something you don't want to sit on. Ossicular chain reconstruction is very similar to tympanic membrane reconstruction. You don't want to do it. You don't want to fix a broken ear bone chain until you're reasonably certain that they have good eustachian tube, because that drum will retract, it will displace the prostheses, and then you'll be back at square one. And every time you operate on the ear, your chances of success decrease, and your chances of causing problems increase. The numbers that are generally quoted is for every tympanoplasty, tympanomastoidectomy, ossicular reconstruction, there's roughly a 1 out of 100 chance or a 1 out of 200 chance that you can cause what we call a dead ear, completely dead. No discernible sound, not amenable to even wearing a hearing aid anymore. So we want to use our surgical options judiciously and not burn any bridges. A tympanoplasty, the first time will work 90-95% of the time. Second time, those numbers drop to 80-85. You compromise your blood supply every time you do a surgery. So congenital oral atresia is the one with no ear canal or a very narrow ear canal. It's a branchial cleft abnormality. It's often coupled with congenital microtia. So when it is coupled with congenital microtia, we work closely with the plastic surgeons to determine when they want to do when and how they want to do the cosmetic reconstruction. There's two ways of doing the cosmetic reconstruction. The first way is rib cartilage. They'll take rib cartilage. They'll take that and they'll carve an ear out of rib cartilage. They'll put that underneath a skin flap and try to make an ear on that side. If they're going to do rib cartilage, you do not do any kind of surgical reconstruction of the hearing until all the plastic surgery is done, because you compromise blood supply when we make an incision behind the ear, and the plastic surgeons are going to fuss over the blood supply to that block of cartilage they're going to put up there. The second way they reconstruct these is called MedPore. It's like a silicon model of the ear. It's really slick. It gives you much more in-depth detail of the anti-helix and the helix and the various little parts of the ear, the scaphoid process. It just looks nicer. It's 10 years ago, I would have said to you, run from the MedPore, because the only thing I saw were complications. It's gotten much, much better. It has much more defined anatomy. There's a much fewer number of physicians doing them, so I think that they're better at them than they were 10 years ago. They have to go to California to get it. There's currently nobody in Arizona who does the MedPore, so I typically send them to California to have that done. There's a number of physicians around here, about 2 or 3, that do cartilage grafts. I just think that the cartilage grafts don't have the detail that you want for a cosmetic result. In any case, we don't do any hearing reconstruction until after a plan for the cosmetic surgery is sorted out. So if I see a child who has unilateral congenital hearing, unilateral congenital atresia, I lay out the timetable for them. They're anxious. You got a 6-month-old with an abnormal looking ear, blah, 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 and you just reassure them that waiting is oftentimes the best. So if it's unilateral, bilateral, if it's bilateral, you have to do something because they can't go around with a bilateral 50 dB conductive hearing loss. They're not going to develop normal speech. And we will typically use a Baha soft band, which is it's like a headband with a bone conduction hearing aid on it. That brings the sound directly into their inner ear, and it helps them develop normal speech and language skills. If it's unilateral, we offer them a Baha. And I'll go into Baha a bunch in a bit. Bone conduction hearing aids we can use as well, but the Baha is just really a better bone conduction hearing aid. And then surgery, again, the surgery is delayed until they're at least 4 years old with the MedPOR, and at least 6 or 7 years old for the cartilage reconstruction. So bone conduction hearing aids, you have essentially three kinds. You have the implantable with an abutment. An abutment is that little metal screw. You may have seen patients with a little metal screw coming out of their head. Hearing aids, the Baha snaps onto it, brings the sound directly into the cochlea. Temporary is the Baha that is on a band that's like a Velcro band that you fit tightly around the head. And the implanted without an abutment is where we put a magnet underneath the skin, and the Baha is held in place with a magnet. It's the most cosmetically pleasing, and it has the lowest complication rate compared to implantable with abutment. So the Baha essentially is bringing sound directly into the cochlea through the skull. If you've ever played around with tuning forks in school and you touch the tuning fork and you hear it, that's how it works. It vibrates the skull, causing a fluid wave in the cochlea. It goes to each cochlea no matter which side. So you could be completely deaf over here, and it will go to this cochlea with no loss of volume. If you have a conductive hearing loss over here, it will go to both cochlea equally. So what it does is it gets sound in the box, if you would, so that they're able to develop normal speech and language skill. This is the temporary one. It's a Velcro band. Here's the Baha over here. You can see the malformed ear. That provides a bridge until they do something more permanent. The Bahas are not approved, FDA approved under the age of 5, so we'll use a Baha in the interim. It's hard to get patients with unilateral hearing loss to wear a Baha. There are several studies that show that it's helpful, but usually if it's a unilateral hearing loss, they tend to use their good side more, and they don't want to do that despite our encouragement. Bilateral hearing loss, they have to use a Baha soft band or have to get something in. This is the abutment we talked about earlier. The advantages to the abutment is it has good volume because there's no soft tissue to attenuate the sound, but you get complications around the post from having a titanium screw coming through your skin. You can get weeping. People complain that they see blood spots on their pillowcase. You can get a soft tissue reaction around this. And then this is the magnet. The magnet goes underneath the skin. There's nothing through the skin if you take that off, and this just gets held in place using a magnet, just like if I took a big old magnet and put it under the table and I took another magnet, and it would kind of snap into place. So that's how that is held in place. They're very stable, very simple, reversible, low complication rates. So what do we do with a straightforward sensorineural hearing loss? Hearing aids are number one, and hearing aids are, the adage used to be 246, now they're bringing it down to 135. Basically, you want to make sure they're screened by 1 month, diagnosed by 3 months, and treated by 5 months. You can't get the hearing aids on fast enough. You want to get as much sound in the box as you can. You want to get them developing normal speech and language skills as quickly as you can. Bone conduction hearing aids can be used for unilateral loss. So if they have one good cochlea, you can put a Baha on the other side, and that will give them improved hearing and noise, and it will eliminate what we call the shadow effect. The shadow effect is if you're deaf in one ear and you sit on that side and you sit on the deaf side, by the time the sound gets around to the other side, you lose about 6 dB of volume. And that 6 dB of volume can make a difference if you're sitting at a table or you're sitting in a row and you're sitting next to someone and you're constantly squirming or straining your neck to point your good ear toward them. What it doesn't give them is sound localization. Sound localization is your ability to tell where sounds are coming from. If I stand 20 yards behind you and 20 yards off to your right and call your name, you will know to look back to your right. Your brain is wired so that it can detect a little bit of a different frequency, a little bit of a different volume, and a little bit of a different timing for you to be able to localize sound. We've all had to call our phones in the house and try to find it, and you walk around following the ringer. It's difficult to do that with unilateral hearing loss because it's all going into the same cochlea. The last treatment is cochlear implants. So cochlear implants are reserved for those kids that have such severe hearing loss that the best hearing aids on the planet do not show a significant response, okay? So right now the FDA indicates that you can do a cochlear implant on their first birthday unless they're post-meningitic. If they're post-meningitic, you can do it at a much younger age because we think that they lose their hearing from meningitis because there's a patent cochlear aqueduct, which is just a tunnel that goes from the subarachnoid space to the basal turn of the cochlea. That the infection goes down there, infects the basal turn of the cochlea, and then the basal turn of the cochlea has a fibrotic reaction, and then you can't get then there's ossification, and you don't have a cochlea or a nice tunnel to put the implant in. So you can put in cochlear implants earlier if they're post-meningitic. They have to have a profound loss bilaterally, meaning right now the FDA has not approved cochlear implants for a unilateral hearing loss. They feel that, and I think that they're correct in this, they're not rationing care, they're not making cochlear implants are no longer experimental, they're FDA approved, but the feeling is that if I take a child with normal hearing and I put a in one ear and a deaf ear on the other side, and we just put the implant in the deaf ear, that child is still going to do 99% of their hearing with their good ear. And the cochlear implant's going to add very little to the equation. Now they're trying to expand the indications and they're trying to develop some tests to find out whether they hear better in noise or whether they're better academic performers with the cochlear implant. But a lot of children particularly will complain about the sound quality of the cochlear implant side. They will say, I hear perfect in this ear, when I put this on it sounds weird. And most of the time, the resources for a cochlear implant, you don't want to do a cochlear implant so that they have increased sound awareness or environmental sounds, fire alarms, smoke detectors, car horns. Is it worth wearing something on your head that's fairly conspicuous, that is only going to help you hear a car horn or hear a smoke detector? Most people won't wear it for those limited benefits. So right now the FDA has said, hold off on unilateral cochlear implants, and they failed a hearing aid trial. So cochlear implant takes sound, you wear what looks like a hearing aid on the outside, and they're getting smaller and smaller. It takes the sound, it hears it, it processes it, and it transmits a signal across the skin to something that is underneath the skin. And this is called the processor. The processor then codes that sound, and it comes down this little wire, and this wire is fed into the cochlea. And it shocks or electrifies the appropriate part of the cochlea, and then the auditory nerves takes that sound and brings it into the brain. The cochlea is tonotopically organized. So the basal turn of the cochlea hears high frequencies, the tip of the cochlea is low frequencies. So in here would be your alto or your soprano, here would be your baritone or your bass, and we take that sound and code it. Most of the improvements in cochlear implants are coming in the way that sound is processed. They sample the sound, they process it, they shock the appropriate part of the cochlea. The electrode improvements are minimal compared to the processing improvements. So a cochlear implant, the hardware should work at least 20 years. They're guaranteed for, I think, 10 to 15 years. So that we're hoping that we won't have to replace the internal part, that the improvements are going to come in this part, and this is just a conduit to present. It's just a tool to present the electricity, if you would. Pediatric indications are lack of progress, 12 to 12 months, profound hearing loss, limited benefit, 2 years older, severe to profound loss, and the longer you wait, the worse the worse they do. We've developed all kinds of slick new tests for determining what we call speech discrimination. Speech discrimination is your ability to understand words. It's not just about sound. We want words. And so we have all kinds of tests that are tapered towards children, so we can give them a vocabulary test or have them repeat words that most 3-year-olds should know or most 2-year-olds should know, so we can determine whether they're able to understand words. So these are what the electrodes look like. They're typically somewhere around 20 millimeters in length. They get fed into the cochlea. It's about an hour operation. Performance is the earlier you do them, the better. This is a busy graph, and I won't go through the details of it, but basically they improve with time, and the earlier the age of implantation, the better off they do. So you can see how this graph goes down with time, and this is the age of implantation on the x-axis. The earlier you get them in, the better off they do. Children implanted under 2.5 years of age achieve higher standard scores than children implanted at earlier ages. The brain is plastic at that early age. It's willing to take the sound. It's willing to take that sound and discern. These are children that never heard speech, right? You don't have a baseline. It's not like you implanted an adult who knows what words are supposed to sound like. But the brain is so flexible at that age that it will take that sound and be able to process words out of it. Why do we make a fuss? Even if you have greater than a 45 dB threshold in one ear, 35% of those fail one or more grades. Children who graduate with a severe to profound loss only read at a 7th grade level. And these are all independent of educational status, socioeconomic status, parents' hearing skills. So bottom line is that it's a big disability. Deaf earn 35% less than the general population. And there's this kind of little, I don't know, kind of almost romanticism about American Sign Language. American Sign Language is a very different language than Signed Exact English. It's not Signed Exact English. It's based on the French language. That American Sign Language is much different than you and I would communicate. And so many of our social norms are based on communication, the way we word things, the way we say, may I have a glass of water, or way you say, or you suggest something subtly. It's a very, very different language, and they tend to be, to go together because Signed Exact English is so different in American Sign Language. So in summary, earlier diagnosis and treatment. Neglect is devastating. You can't just say, just watch it. Common things happen commonly, right? What are the most common causes of hearing loss? Wax, fluid, eustachian tube dysfunction. Aggressive treatment when you have a real sensorineural loss. We consider it a developmental emergency to get the sound in the box. Speech is the primary goal because we don't really care about thresholds. We care about their ability to develop normal speech and language skills, because that window is closing, and that window closing is an emergency to us, and we need to get sound into the brain, whether it's through a cochlear implant, a Baha, a hearing aid, or whatever method. We need to get sound into the brain so that they develop normal speech and language skills. I think I've run over.